Hello, this is Jordan Reese, U.S. Sales Director of 3D Imaging for Carestream Dental. We'll be joined in just a moment by Dr. Shalice Katal to do a CBCT anatomical review of the temporomandibular joint. Let me introduce Dr. Katal, who is an experienced oral and maxillofacial radiologist. He has an extensive knowledge in both the radiology and 3D imaging fields, with a specialized focus on cone beam CT imaging technology. Trained at University of Missouri, Kansas City, Dr. Katal now serves as the Director of 3D Imaging at Carestream Dental. His most recent appointment included acting as Clinical Assistant Professor at NYU School of Dentistry and serving as the head of a specialty group of oral and maxillofacial radiologists. In his roles, Dr. Katal has been asked to speak extensively on various aspects of clinical radiology in national and international venues and has served as a keynote speaker on numerous occasions. Dr. Katal remains on the cutting edge of technology by maintaining active clinical research involving radiology and 3D imaging. Dr. Katal, welcome. Thank you for joining us on Carestream Dental's University program.
Thank you for having me again, Jordan.
I'd like to state before you get started, again, this is a cursory overview. This is not a full radiology read. This is not intended to serve as a complete overview of the scan. This is an anatomical review of the temporal mandibular joint. Dr. Katal, before we jump into 3D imaging, I've noticed that many clinicians still use 2D imaging for evaluation of the TMJ. Is that all that's needed? For example, as this image here, does 2D imaging alone suffice for TMJ evaluation?
Jordan, I think you just brought up a very good point. The reason 2D imaging is more prevalent among the dental community is simply because it is more available to the dental community as opposed to three-dimensional imaging. But that has changed. 3D imaging provides much more details in terms of analyzing the anatomy of TMJ. So there is a small shift, or a big shift, in fact, that's happening towards moving from two-dimensional to three-dimensional imaging of the TMJ.
So you're emphasizing that it's the third dimension that's critical, and that's what's missing from the 2D radiographs.
I think you have nailed the point. That is exactly what it is. You know, it is the third dimension, as I've mentioned earlier in our previous discussions. A 2D image is nothing but a two-dimensional representation of a three-dimensional structure. So one of the things that we lose is the capacity, or the third dimension, which is nothing but the depth. You can analyze the breadth, you can analyze the width or the height, but you're not able to assess the depth, which is the third dimension. And by moving towards CBCT imaging or any form of third dimensional imaging, that is one of the biggest advantages. You're able to now see that dimension which could not have been visualized on a static radiograph.
So what are the indications for use of CBCT imaging in visualizing TMJ?
Well, it is very simple. As I've noted before, CBCTs can be used for or applicable in any kind of hard tissue imaging. So anytime a clinician suspects some sort of osteoarthritic changes or any change in hard tissues, if you suspect that there could be possible changes in the hard tissues of the TMJ apparatus, CBCT scan is very well warranted.
So what specialties in dentistry deal with temporomandibular dysfunction?
Well, it's more than one. Oral surgeons have a very good handle on that. They do numerous procedures on temporomandibular joints. So oral surgery is one community that does a lot of work on the TMJ area. Orthodontics probably deals it day in, day out with correction of occlusion and things like that, you know, which hinges on the bilateral temporomandibular joints. And general practitioners get to see a lot of patients that have temporomandibular dysfunction as well. So it is more than one specialty.
Before I hand this over to you, let me just give a quick overview of what we're looking at. We begin with an axial view in our custom slicing tab. The custom slicing tab in our CS3D imaging software is specifically set up for TMJ analysis. In this view, you'll see that we begin with the axial view, a 3D rendering of the right side of the patient and an additional 3D rendering of the left side of the patient. To begin to do a TMJ analysis, we click on our TMJ creation mode. And with simple 2 clicks, we begin by creating lines through the area of interest, creating a anterior-posterior for patient right and a lateral view for patient right, the same views for patient left. One of the new features in 357 is zoom. And of course, we can always zoom in all views, but it used to have a separate default that every image could be zoomed separately. But to do proper TMJ analysis, we've now set it up that you can change your zoom so that there's synchronization. Clicking on the second icon allows for all 4 screens to be synchronized. Clicking on the third icon allows just one lateral side to be synchronized. And the fourth icon allows for the anterior-posterior or lateral views to be synchronized. With that said, let me bring this over to you, Dr. Gattal, and start with a question of, could you show us the anatomical landmarks to be noted on a scan of the TMJ?
Well, this is getting much more interesting. Okay, so let us start with the scan. So I think, Jordan, what you just showed was how to reconstruct the multiplanar views in a TMJ image, and it looks great. So let me start off with a couple of things just to reemphasize on what Jordan said. You have the anterior-posterior view on the top. You have the axial view. You have the lateral view, which is nothing but a view from the side of both the joints, and of course a 3-dimensional reconstruction. Now the 3-dimensional reconstruction is obviously very a critical tool when it comes to explaining something to the patients. Now, once we get with that, let us look at the basic anatomy of the temporomandibular joint. Let us start with the condyle first. So this would be the lateral pole of the condyle. When you look at the anterior-posterior view, the lateral pole, the outside edge of the condylar head is the outside edge of the condylar head. Let me just do this real quick. What you see over here where my cursor goes, that's the outside edge of the condylar head, and that is the lateral pole. And the inside edge is the medial pole. And the same applies for the contralateral side as well. You notice that is the lateral pole, and the medial pole comes in the medial edge of it. Now, when you look at the lateral views, you notice this is the anterior aspect of the condyle, and this is the posterior aspect of the condyle. Since we are looking at it from the side, keep that in mind. And this is also the anterior aspect and the posterior aspect of the condyle in bilateral areas. Now, besides the condyle, there are 1 or 2 other structures that is very prevalently seen on a scan. And one is the articular fossa, where you see the curved structure, the nice curved structure above the condyle is the articular fossa. What the space in between is where the disc occupies. So that is almost referred to as the interarticular space. And besides that, now we have, if you look at the lateral view, you can notice that there is eminence, which is nothing but the articular eminence. This is visualized bilaterally. The eminence is a very critical component to the TMJ, since most of TMJ movements are related towards how it's oriented with the articular eminence. Now, what do we look for? What do we typically look for in these things? When we look at the smoothness of the surface, we look at the smoothness of the structure of the condyle. We look at the smoothness of the articular fossa and any kind of other changes. You also do see a little bit posteriorly, you see some mastoid air cells, which is nothing but, as I'm pointing out right over here, these are the mastoid processes in which mastoid air cells exist.
Dr. Gattal, you've explained well the normal anatomy. We are looking at a scan from the CS9300 premium and this is one of 7 different fields of view. This is specifically a 17 by 6. The 17 allows for bilateral anatomy. So could you specifically comment on the bilateral anatomy that you see here on screen?
See, Jordan, one of the biggest advantages of actually having bilateral anatomy on a single screen is the fact that you're able to compare and contrast both the condyles of the same individual at the same time. You know, and that is very essential when you evaluate a joint that is not a single joint, that's actually a dual joint, so to speak. So one of the few things that you can look for, apart from the anatomical landmarks, is the smoothness of the surfaces of the condyle, of the fossa. Now, you can see the cortical bone over here. It kind of thins out on the superior head, maybe superior medially. It kind of thins out a little bit, indicating some sort of like a degenerative change. Now, in this case, you can see the condylar head, the cortical bone is not even that pronounced as such. And then you can look at the smoothness of the shape of the cortical bone by itself. And let me just go ahead and do this. Let's go ahead and take a look at that particular anatomical region all the way from the medial head to the lateral head. So what we're doing is we are going through the scan, and we are trying to see if we can notice any changes on the shape of the condylar head. And there you go. You see the first change over here. You notice some sort of flattening. You know, in fact, you can see on the lateral side, you can see on the superior head. In fact, there's actually quite a bit of loss of cortical bone there. And then as we go further lateral, you can see a remarkable indentation indicating possibly a very chronic degenerative disease, osteoarthritic disease on that side. And how do we, once we have done with that condyle, immediately it is a good idea to go ahead and do the same on the other condyle as well, so that we can get a correlation between the two condyles. So we go back again, we go from the lateral pole all the way to the medial pole. I think that's a good place to stop, and I can show you how there's a significant difference. You also see some sort of like a remodeling that's happening on the medial pole, you know, which again indicates osteoarthritic changes. In fact, it's not really smooth and rounded, as I had mentioned earlier. There's a little bit of corrugated kind of appearance, maybe a little bit of break in the cortical areas right there I'm pointing to, again indicating degenerative disease or bone remodeling. And then I probably would stop over there and show you that there's a remarkable loss of the cortical bone on the superior head of the condyle right there as we go further back posterior. And just to complete, you know, we look at the entire posterior surface as such. Now, that is anterior posterior view. Of course, now we have the advantage of actually seeing the lateral view. We are able to now see the lateral view all the way from the lateral pole of the condyle to the medial pole of the condyle. And let's do the same thing in this case. Let's start from the lateral pole of the condyle, and let's travel all the way through. And we did notice some sort of an indentation. Remember, I mentioned that? And Jordan, let us stop right there, and let's look at that indentation. See that indentation on the head of the condyle, and look at what we see right over here. What we see is quite a bit of change in the remodeling of the condylar head by itself. And then let's go a little bit more further medially, and let me just stop over there and give you an idea what we're looking at. Right over here, there's quite a significant amount of flattening on the superior head of the condyle. Now, that clearly is an indication of bone remodeling again. So by going through these slices, one of the biggest advantage is that you're able to now see different areas and different aspects of the condylar head and be able to individually segment out each single area. In this particular view, you do notice that the cortical bone itself has degenerated, and there's a break right there. So again, emphasizes on changes, remodeling. And for the sake of consistency, we are going all the way to the medial pole. And let's just stop over there and shift over to the other condyle. Let's start with the lateral pole. Let's see how the lateral pole of that condyle compares to the contralateral side. So it looks fine as we go through. We do notice that there are some changes, and this right now, what you're looking at is a classic example of a beak shake experience, which is nothing but an osteophyte. This is explained in textbooks as one of the best ways to identify bone remodeling in degenerative disease in temporomandibular joints. Again, we are going through furthermore into the condylar head. If you notice, again, I'm going to stop right there, show you some sort of flattening on the superior head of the condyle, superior anterior portion of the condyle. Almost looks like the contralateral side. For the sake of consistency, we go back all the way to the medial pole, and just let's go ahead and stop there. So in a nutshell, what we were able to look at these different slices and understand was there was some sort of like a degenerative disease in this patient. There was a significant amount of bone remodeling, and this is the kind of detail that is missing in a two-dimensional radiograph when we do. We are not able to negotiate through different sections, different planes, correlate the intra-anatomy of one particular joint and compare that with the contralateral side. So I think this is a huge case to use three-dimensional imaging for TMJ analysis.
Yeah, it's so helpful to watch you navigate through here. I mean, that's the key word. You're moving from anterior to posterior. You're moving from medial lateral, and it really demonstrates very clearly what is lacking in a 2D a TMJ view. Let me ask you a question. Is the articular disc visualized on a TMJ scan?
That is a very common question that I get as well. So to make this very clear, articular disc is a soft tissue structure. Soft tissue structures cannot be visualized on CBCT images. You might be able to see some contrast here and there, like we discussed on an earlier discussion. I did say that you're able to see something in the sinuses because the air background is nothing but air. But in this case, that's not that is not exactly how it is. So articular disc cannot be visualized on a CBCT imaging. If a clinician needs to see the articular disc, the best modality to go to is a MRI.
Excellent. So MRI is much better for visualizing soft tissue, and CBCT without something that's very far away in terms of contrast isn't able to visualize soft tissue. But is it possible to do an open view of the TMJ using CBCT?
Absolutely, and that is one of the big advantages of CBCT. It is possible to do an open view, and when you do the open view, one of the reasons that open view is done is to understand the translation of the condyle from the closed position to the open position. And when you do an open view, and one of the big advantages of having a fast scan mode is that you can keep the patient's mouth open for less duration, do a fast scan, thus avoiding any other issues, and even the patient fatigue between doing two scans. So to answer your question, it is absolutely possible.
So are you implying that, like with our 9300, which has a fast scan modality, that this would work best for the open view? Would you say that the 9300 and the fast scan modality is a major plus of the system?
That is correct. The fast scan mode not only has the advantage of actually doing a fast scan, but it also, I think, one of the critical advantages of a fast scan mode is that you irradiate the patient much less than doing a high-resolution scan. Because like I mentioned earlier, the reason to do an open view is to understand the translation of the condyle. So you capture all the anatomical details on the close view and do a fast scan with less radiation, and you get enough to understand the position of the condyle in relation to the articular evidence. And that is a huge advantage.
So to reiterate, you get the detail in the first with the closed view, and if you do need to do the open view, you can do it in low dose. You have the detail that you need in the first scan, and you can still visualize the articular eminence very well. So what is, to conclude, what would be the most ideal techniques to avoid any motion artifacts, especially when doing something like open and closed TMJ?
That's a very good question. So that is a technique-related question. So one of the key things to notice while doing any scan for that matter is to actually stabilize the patient's head. with all the restraints that are available as a kit with the unit. It is important to stabilize the head first. Once you stabilize the head, you have to stabilize the jaw in an open view. How do you do that? Even though it's a short duration of time, you can use an intraoral bite block just to keep the patient's mouth open so that the patient can bite on it and avoid any kind of muscular spasms that could create any kind of motion artifacts. Motion artifacts is one of the major reasons why scans don't look good. And again, let me emphasize over here, the fast scan mode is the best way to go. When you keep the mouth open for as less duration as you can and use the fast scan mode, you're able to avoid probably the most amount of possibilities for capturing any kind of motion artifacts.
Excellent. And as can be visualized here, we've got the bite block in. We show the specific control that is here for a TMJ. What's not visualized is the temple clamps, the possibility to add a head strap if necessary. And of course, as with all of our cone beam CT, the patient can be sitting or standing. Dr. Katal, I think this is a great overview, and I really appreciate your time. I hope maybe you'll come back to join me again, and we can find some other subjects, questions that we get that you would be agreeable to answer.
Absolutely, Jordan. I'm looking forward to. I can learn a lot of stuff from you as well.
Excellent. Well, thank you so much. I really appreciate your time. For those that are watching these videos, if you have additional questions or want to contact a Carestream Dental representative, you can always reach us at 1-800-944-6365 and visit us on the web at carestreamdental.com. Additionally, here is my contact information should you need to reach out to me. And thank you very much for taking the time to watch another session of Carestream Dental's University program.